All right, so we're going to go, and I'm going to introduce our closing keynote speaker. Our closing speaker is going to be Rishi Manchanda. He is the Chief Medical Officer at The Wonderful Company, a privately held $4 billion company committed to offering consumers high-quality, healthy brands. Rishi is also president of HealthBegins, an organization that provides healthcare providers with upstream quality improvement tools to improve care and the social determinants of health. Prior to joining The Wonderful Company, Rishi worked for the VA Greater Los Angeles Healthcare System, where he was the lead physician for homeless primary care, and for a network of community health centers in South Los Angeles, where he was the first director of social medicine and health equality. In 2008, Rishi founded RxDemocracy, a nonpartisan coalition that promotes civic engagement and voter registration in doctors' offices and hospitals nationwide. In his 2013 TEDbook, The Upstream Doctors, Rishi introduced a new model of the healthcare workforce that includes upstreamists who improve social determinants of health. Rishi earned his bachelor's, medical, and master's of public health degrees from Tufts University and was the first graduate of UCLA's combined internal medicine and pediatrics residency. Join me in welcoming Rishi to the stage.
Good afternoon. Do you guys want to take a little stretch? Why don't we all stand up in place right now? Just do a 2-minute stretch. There you go. How about a twist to the right? There we go. And twist to the left. Hold it. Breathe. And let it out. There we go. No one leave the room. You can if you want to. Please, thanks. If you want to keep on stretching, it's okay. I won't take offense, but we can form a little yoga club in the back. It really is a privilege to be here today. Thanks to Lauren, Kara, Anthony, Tom, Lee, Heather. Thank you so much. I'm seeing a lot of folks in the room. Zool is back there. Hey, Zool. I'm seeing a lot of folks who I recognize and a lot of new faces here. Again, how many people here are students? Yeah, I don't know any of you. But now we do. It really is a privilege here. I was honored but a little perplexed as to why somebody who spent the last 8-9 years uniquely focused on domestic issues has been asked to have the privilege, really, of addressing you guys talking about global health. And I think part of it is because a lot of, as Tom and Lee know, a lot of my interests and a lot of my passion really derive from my life really living in the U.S. and abroad. As many of you who are children of immigrants, by definition, you are a global health person or a global person because, like myself, my parents grew up in India. They came here in the late 60s. I was born in New York, went back and forth quite a bit living in India as a kid and then coming back and living in Texas. You know, there'd be like Rajma Chawal, for those who know Indian food, and then there'd be Chuck E. Cheese pizza. I mean, it was a weird contrast, right? Kind of living in the middle. And so I always had an experience just knowing what other parts of the world were like, specifically India. And I also had an acute sense of how, growing up, how major events that we see sometimes in history or on CNN really manifest in people's lives on the ground. My own family used to be from what's now part of Pakistan, and as many of you know, in global history, there was an event that led to independence for India and Pakistan. It cleaved the South Asian subcontinent, and millions of folks in both directions, Hindus and Muslims, just crossed paths, and my family was one of those. And I can't tell you how many stories growing up as a kid at my grandfather's knee were stories as filled with direct, visceral memories of what happened when a family picks up and moves over and has to start life over again. Geopolitics was something that was shared at the dinner table, right? So when you have an experience as a kid, as many of you I think do, knowing what it's like to be not entirely American, but entirely American at the same time, right? Because that is the quintessential American story. It's no surprise then that you go on a path that many of you are going on, and at least in my regard, that I went on, and that connected domestic work, domestic focus with a global health perspective in a way that sometimes even pushes the boundaries of what those terms mean. For me, domestic and global still doesn't fit right. It's the best words we have, but it doesn't fit right because I don't see myself as someone who has been limited by those definitions. I've been spoiled by the privilege of being able to take the best of what I've learned in work abroad and the work here and see how we can make the best available care available to the underserved that we care for in the US, and maybe even learn lessons that can go abroad. So before I go into some details about what this title means, what does moving upstream really mean, I'll tell you a little bit about the work experience. I'm inspired by what Heather, Shirley, and Lee and Tom were talking about. When I was in college, I came across a course that was the political economy of world hunger. It was a grad level seminar. I snuck into it and got some course credit here, and I came across the story of a place in Southwest India called Kerala. And Kerala, to many who know, in the global health community, you know that Kerala is one of those places that has achieved great social development scores, infant mortality rates that are very low, literacy rates that are very, very high. By all measures, an incredibly healthy place. And yet it was, at that point, and still is, one of the poorest parts of India, a poor part of the world. So how was it possible that a poor place could achieve incredible health indicators? And of course, you know the stories of Cuba and Costa Rica and other places that have a storied tradition in global health circles, right, of these anomalies. I realized early on that I love anomalies, right? I love going for understanding why an outlier is an outlier. And so I had the privilege of being able to spend a summer and then a full year in India later on trying to unpack what happened in Kerala and other parts of India. And along the way, I met people who were incredible role models for me, mentors. Mentors who happen to be physicians, but more importantly were community change agents, right? In Kerala, for instance, you would find a doctor there as likely to be spending a day in clinic as on a Wednesday as you would finding him on a Thursday going in and joining with sanitation public health specialists to do a survey of access to clean drinking water or toilets, right? The line between public health and medicine was not a wall, it was a clear spectrum in places in the world, and I thought, that's what I want to do. I want to be that type of person who has those skills to care for somebody individually, but someone with a perspective that was global. So I came back to the US, I signed up for a program called the National Health Service Corps. Anybody hear about that program? So now you have, for those who haven't raised your hand, the National Health Service Corps, Google it, bookmark it now. Phenomenal program, and I know there is now the Global Health Service Corps, there's other kind of examples that are coming out, but the National Health Service Corps was a program that allowed me to pay for med school. I'm just gonna pause there, right? You heard what I said, right? So now people are Googling for sure. But more importantly, it committed me to a life and to work for the underserved. And so when I was fortunate to get that scholarship, I came out to Los Angeles, and I came into Los Angeles just like you've heard from Heather's story and other stories. I came to Los Angeles because primarily my fiancée, now wife, at the time said, you gotta get someplace warm. We were in the Northeast, in the Boston area. She was in Vermont at the time, and she said, we gotta get out of here. And the reason she said that was because she was, her parents are from India, but she was born in Zambia, raised in Botswana. And her thermostat was set very high, right? And I remember driving to visit when we were long distance dating and seeing her apartment like from 500 yards away, and I could see the snowpack on the Vermont kind of apartment complex she lived in. And the snowpack was like 3 feet high. And then I'd see her apartment, and I always knew it was her apartment because the snowpack was like 3 feet lower than the rest, right? Her temperature, her thermostat was set so high, it was like a sauna where she lived. So no doubt I had to get the same place warm, and I listened, and one of the wisest decisions I've made in my life is to listen to my partner. So that's my advice. So we came out to Los Angeles, and I was fortunate to start the Medpeds residency program, to be resident in the Medpeds program here, and met incredible role models along the way, people who I'd knock on people's doors like Tom and Lee's and say, I'm not sure what I want to do, but I know I want to do it. Does that make any sense? No? Okay, well, let me ask more questions. When I finished my residency, I went out and I worked in Venice Family Clinic. Anybody know Venice Family Clinic here? Great clinic. did a 4-10 schedule, meaning you do 10 hours a day for 4 days a week to get your 40 hours in. And I did that so I could compress my work week so I could have Thursdays off. And on my Thursdays off, I went over to South Central. It's now called South LA, but it was South Central at the time. I went to South LA, and I was fortunate to work with a community health center there that asked me to be the coordinator for a homelessness collaborative. And the reason they asked me to be a coordinator for this collaborative was because I just said I'm willing to do whatever it takes to just work here. And they said, here's a job opportunity. We don't know if you could do it, but we're desperate. So oftentimes, whether it was Heather, where's Heather at? Heather talked about being the photocopier, right? You do what's necessary, right? If you want to get started, don't wait for the perfect because you'll never get there. Do the work that's necessary, especially because in communities where the need is greatest, if you don't actually walk arm in arm with somebody and say, I'll be willing to photocopy or just serve that role, however different it is from your expectations, then you're not creating solidarity, you're not earning trust. So I had the privilege of walking to that position, and what happened after about 4 or 5 months was an interesting opportunity to take what I'd heard about internationally, the UN Declaration of Human Rights. Have you guys heard about that? Yes? Great. How many of you have actually read it recently? Good. Well, you don't have to, right? It's not like bedtime reading, and it's not a page, it's not like a vivid, it's not a novel that's on the top of the New York Times bestseller list. It's not something that's kind of gripping, unless you're people in this room, right? Global health people are like, that's awesome, this stuff is great. The problem is it always felt so distant when I was doing work in India and thinking about international work. When I was sitting there with folks in South LA, the CEO of a clinic, the head of an affordable housing agency, a promotora organizing group, a tenants' rights group, all who were part of this collaborative to understand what was happening around homelessness in South LA. You had people from housing and health and tenants' rights and civil rights organizations all at the table, and they all knew each other, but they were using different words. And I said, well, maybe we can use the UN Declaration of Human Rights. Maybe we can actually take the health and human rights framework. As you know, that's a framework that's evolved over the past 20 years. Maybe we can take that and actually adapt it here. Why don't we create the South Los Angeles Declaration of Health and Human Rights and adapt that UN tool to actually make that document a living document and a mobilizing tool to bring together different constituents? And somehow, because they were crazy enough to listen and I was crazy enough to say, I'll help make it happen with you guys, there was a bunch of folks at the table who made this work. And fast forward a few months, we had 1,000 people in a room as part of the first meeting for drafting the South Los Angeles Declaration of Health and Human Rights. Preachers and doctors and lawyers and promotoras and patients sitting down and actually developing the South LA Declaration. And if you go right now and you Google it, you'll still find that declaration. The annual conferences goes on to this day. They've had 6 gatherings over the past 6 years, every year. And what came out of that first year was a series of meetings where the community helped to draft the declaration itself. And they are signatories. We went out and we went to local politicians, including the supervisor for South Los Angeles, to key influencers like the head of the California Endowment and others, and we said, can you sign this? We contacted the UN Rapporteur on the right to health. Right? The UN has this body that allows you to monitor the ways in which countries around the world are adhering to the human right to health. And we said, we're in South Los Angeles, we're kind of off your radar here, we're the US. But there's a lot of issues that are happening here in South Los Angeles that are really not dissimilar from what you're trying to tackle in other parts of the world. Pervasive discrimination, pervasive structural racism that has led to the health disparities and inequities that we see here today. Can you come and just visit us and see if there's a connection between that international work and what's happening here? And so the UN Special Rapporteur on the Right to Health came to South Los Angeles. So here I was, seeing patients 40 hours a week. I had a couple hours off, meeting with people talking about health and human rights. The dream job, right? And it happened in part because another piece of advice besides listen to your partner is never stop asking, because the worst answer you can get is no, right? And even that's not a bad answer. Because no just means, well, while you're saying no, then you can get to yes later on. Because eventually, if you realize that a lot of what are anomalies and outliers, there are really signs of a different way, a better standard of care, a better way of actually being a professional in a global health context. If you realize those examples are out there and you spend enough time out there, you get a taste of what it's like, a glimpse of what it's like to be better, of what it's like to be professionally satisfied, of what it's like to have a vision in which you have that family integration. And when you taste it, you want more of it, and then you start asking questions about, hey, can we do this? Can we try for a job that allows me to do a little on-the-ground work and a little bit of policy work, et cetera? So I share that to say that since then, I never stopped asking about ways to connect what I've learned outside the U.S. to stuff that's happening in the U.S. And one of the things that happened along the way in that work in South LA, and since then, after working with homeless veterans at the VA hospital, and now, as strange as it sounds for someone who had that career path to end up working for a large privately held company that is actually trying to improve the health of its employees and their families in the Central Valley of California, farm workers. What's interesting is that I've seen a pattern of opportunity and of success by moving upstream in each of those settings. And that's what I want to talk to you guys about today. Is that good? Like, what does moving upstream look like, and how is that thread of moving upstream in South Central Los Angeles, moving upstream when it comes to taking care of homeless veterans and improving outcomes dramatically for them by connecting them to housing and law, and now moving upstream with a large self-insured employer in the Central Valley of California. What's the thread? So, the international context, you guys have talked about this today. I don't want to belabor it, but I want to call out some of the inequities. The most upstream of all drivers of things is this power and imbalance of power. So we know that there are a lot of inequities, right, between countries. We know that there are inequities, for instance, in terms of life expectancy across the world. I'm not going to belabor this point. You guys can read. We know that it's vast. These inequities are grave when it comes to everything from life expectancy to maternal mortality rates. We know that within countries, there are also, of course, inequities. Have you guys seen the county health rankings? Anybody see the county health rankings report recently? Another Google bookmark? I'm just going to keep on doing this, right? This is the age of social media, so Google bookmark or tweet look, to search whatever social media you need to search and look at county health rankings. Besides the UN Declaration of Human Rights, please look up county health rankings. This is Global Health 101 in the Rishi context. All right. County health rankings came out from Robert Wood Johnson Foundation several years, supported by RWJ several years ago, started to actually map out life expectancy and other health indices in counties all across the U.S. And what it did was to do what we've seen in other parts of the world, what the Human Development Index has done in many parts of the world, is to give us insights into the disparities within countries, within regions. And we know, for instance, in Washington, D.C., life expectancy varies if you just go 3 subway stops away on the metro, right, dramatically. And we know that, of course, these disparities persist and persist. So these inequities, specifically, that exist are the context that we're working in. We know that we're seeing a huge trend right now towards the convergence right now of a double burden of both communicable and non-communicable diseases, right? Acute issues like HIV, TB, et cetera, now meeting the rise of cardiovascular disease, of diabetes. You look at the projections over here right now, and you look at the CVD bar, and you see how that compares now to the pink, the salmon kind of wedge above it, which is HIV. You realize what's happening right now in the world is pretty drastic. Not only are there intra-country and inter-country disparities, but there's also now this trend, driven by demographic shifts, and driven, frankly, by political choices that are being made and policy choices that are being made both in the developed and the developing world. Who's determining how money is spent on food? Who's determining how money is spent on other issues? We know that there is a burden. The places that we go visit, the people that we connect with in places like India, like Malawi, et cetera, are often dealing with huge inequity when it comes to decisions we've made. Our assistance sometimes actually is putting countries in a situation where they're spending more in many parts of the world and paying off debt than they are in getting development assistance, right? This used to be called something in other parts of the world, sharecropping, right? Indentured servitude, right? When you put somebody, we say, I'm going to give you some support, but I'm going to actually take more out, so you're always going to be in the hole and digging down. Well, we know that story well. In fact, we unfortunately know it far too well in the U.S., right? It's important to understand that inequity because it's playing out in real time. And it's the context that we walk into if you're thinking about work in LA or you're thinking about work in Malawi. Now let's bring it home to the U.S. Again, I'm going to bring home this context to the domestic experience that I can talk about. You guys are aware of how much we spend on healthcare in the US, right? I'm going to connect this story of how much we spend on healthcare in the US now to these choices that are being made that inform international work. So, we spend a lot of money in the US, but do you know that we're the only country among our peer nations that spends more on healthcare relative to social services compared to everybody else? Look at this bar graph and look at the red bar over here, right? We spend, I'll get to that graph in a second. So in a couple beats, I'll show you more about that slide, but this just tells us, of course, we spend a lot of money on this, right? More per capita, both in public and private expenditures on healthcare. So we're spending a lot of money in the US. We're seeing this trend in more and more in other countries. More countries are spending, thankfully, more money on health. But in the US, we spend so much and we get so little, right? You would think that compared to our peer nations, we would get a lot of value out of that, but we're not. 17th out of many countries when it comes to male life expectancy, 16th and compared to peer nations. So one of the things I want to challenge you is this question of value. And increasingly in the US, value is a question, but increasingly, of course, in the international world, in global health, value is the question. Is the way we're spending our money the right way, right? Both in the US and internationally. It's probably not if you look at just the US context. And if the US context is a big determinant of how choices are made in spending elsewhere, then we need to really challenge how we allocate resources internally, lest other countries start to model, right, our spending habits. If we go healthcare heavy and get only this ROI in other countries of the world, what will happen, especially if we project over the next 10 to 15 years, over your productive careers? In the US, this has been called the health disadvantage, the US health disadvantage right now. When the Institute of Medicine several years ago looked at how we're doing in the US compared to a lot of our peers in other countries, we found that the US actually fares worse on several different indicators. Infant mortality, HIV, heart disease, lung disease. And this was true for rich and for poor, which means if you're a rich American, you actually are less healthy than your peer rich person in Germany or France. That's just as true right now based on the science as, of course, if you're a poor American compared to peers in the same socioeconomic status. This is a meaningful point because a lot of the kind of conventional wisdom right now that even percolates surprisingly in global health conversations is, well, Americans are poor because our poor health, our less return on investment is because we have poor Americans, and it's because we have such poverty and such poor outcomes because of that poverty. That's what's dragging us down. It's actually only partly true. Right? Rich and poor Americans alike actually are faring worse in terms of health outcomes compared to our peers. So why aren't we getting better value, right? Let's talk about the US context, and again, think based on the passions you have for working abroad, think about this conversation in context of everything that you are doing or want to do abroad. Why aren't we getting better value in the US? Well, part of it is because we've used an approach that's actually been quite silly, right? It's called the fee-for-service model or the volume-based model. I want to pause here because there are conversations and funding mechanisms and choices that when you guys walk into other contexts and you do work in other parts of the world, ask yourself how the work is getting paid for on the ground. How is that doctor that you're working alongside or that nurse that you're trying to support or the community health worker, how are they getting paid? And if they're getting paid in a fee-for-service system, there might be something that's actually worth asking more about, right? It's not necessarily that fee-for-service is inherently bad, but if it's the only thing, we know in the US example that it can lead to really bad outcomes. Again, less investment. Let me give you an example of what fee-for-service means and what fee-for-value means. So let's take an example of something that you guys will probably experience in about 15 years. You want to renovate your bathroom in your home, right? You want to take on a project and you're in your home and you want to renovate the bathroom. Anybody have a family member who's done some renovation in their work sometime in the past 15 years? Your bathroom was remodeled. You know what this is like, right? What's the business model? You go out and you actually recruit some contractors and you say, I want to get a bid from each one of you, and if you bid at a rate that's agreeable to me, then we'll sign the contract, and I expect a certain outcome, a certain value for that, a better bathroom. And you know the contractor's going to fudge it by about 15, 20%. That's what they do. But you do get that value at the end of it, hopefully. And if you don't, then you're rated on Angie's List or something, and then you don't use them again. Now, if you use the healthcare business model that we've evolved in the US, and that drives a lot of what's happening over here, A lot of what's been happening is something that would be considered absurd at that ground level. Let's use the healthcare business model about renovating the bathroom. In this context, what would happen is somebody knocks on your door. You don't know you need a better bathroom, but somebody knocks on your door and says, I want to get a better bathroom for you, and I think you need some diagnostic testing on the wires behind your wall. I'm an electrician. You say, well, come on in, thanks. Yeah, that's a good point. Let me do that. And they say, well, I'm going to charge you every time I do the testing, but trust me, you need it. The doorbell rings. A plumber shows up. Listen, I have the best fixtures for you. Some really great fixtures for this bathroom. They're the latest upgrade. They're titanium. You need these fixtures. Let's get you these. You say, well, of course, you know what you're talking about. Let's get it. And of course, you're going to charge me every time you do that. Yes, of course. The interior designer shows up, and the interior designer says, you know, you really need a marble fireplace, and the best bathrooms have this. Right? You need to get this. And so you end up actually getting what you think is going to be the better bathroom. But at the end of the day, when everybody leaves, you're sitting there and you realize, wow, you have a really beautiful bathroom, you think, but it may not be functional. I mean, there's no toilet. And the next morning when you get up and you use that beautiful bathtub and you step out and you slip on the marble floor and you hit your head and you're looking up at that angel, and you're like, wait a second, I just realized something. I just walked into a trap here, right? I walked into a model in which every time I get a service or a fixture or a diagnostic test, I'm getting charged, which means those guys who are serving me are incented to overcharge me and, to the extent I can pay, overserve me. And if I can't afford to pay or somebody can't pay on my behalf, well, they're going to overcharge me anyway and underserve me, right? Welcome to the American business model for healthcare. Fee-for-service creates perverse incentives and has done so for the past 60 years. And we're now in this moment, actually, in the past 6 years, because of work that happened pre-Obamacare, but especially accelerated because of Obamacare, there has been a shift driven by payers in the commercial sector and then the government saying, we don't want to keep on spending money for this anymore. Large companies, IBMs and others, saying, I don't think what healthcare is selling us is worth it anymore because we're getting people who are still sick, and you're overcharging us and maybe overserving us. So you see how the incentives sometimes can line up in a way that can be really perverse and lead to maybe waste? Well, it turns out a lot of things can happen out of that. You get overuse. In the US right now, we're spending more compared to our peer nations on MRIs and CAT scans and all these other wonderful procedures at a rate that perhaps is more than we need to, right? Overuse. It's estimated that 1/3 of all that money, $3 trillion, approximately $3 trillion in the US, is waste. Inefficiencies, just waste created because of, again, those plumbers and electricians don't talk to each other, right? The contractors that we have in our system, the providers, the hospitals, et cetera, just don't talk to each other. There's no incentive for it. Why do that? That's going to take away from our bottom line. So we create waste, 1/3 of waste in the American healthcare system. And this is what I was referring to earlier. It's also because of that, what ends up happening is we spend up more as a society on healthcare than we do on social services. And the reason this is important is because we're an outlier in a negative way. I think in a negative way. I'll leave it to you to determine what you think. But we are an outlier. Our ratios in terms of spending on healthcare compared to social services are lopsided compared to every other nation in our peer group. What I'm talking about, it really is an opportunity cost for that bathroom model, right? What ends up happening in that bathroom model is the next morning when somebody rings the doorbell and says, hey, listen, I want to ask you a question. Do you think you have the best bathroom on the block? You say, well, of course. Look at my bathroom. What are you talking about? What, are you Canadian? Why are you asking me questions about this is the best bathroom on the block? What are you talking about, right? So you start getting defensive about this, and you don't, as you're defending something that you think is the best, because we all do that, we all want to do that, compare ourselves to our peers, you end up realizing that we're actually paying for this in many ways. When we're getting everybody building that kind of better bathroom and not getting the value that we want, we're paying for it another way. And what we've done in the nation is actually make choices along the way that have spent more on healthcare than social services. So the reason that's important is because it's created pain points in the US. And again, think of the pain points as these exist in international contexts. Because the US model right now of healthcare is becoming a default model for a lot of places. And it's important that the people that we export who are passionate are able to transform the systems, lest we have the same systems exported abroad too, right? The pain points that are a result of the American experience that we've had so far lead to a lot of pain. We have folks at the bottom of the household, the bottom of the socioeconomic gradient, who are spending about $1 out of every $5 on healthcare. When you're talking about higher income folks, it's only 3%. We know that primary care in the bottom over here, primary care in the nation is starved, right? Only 5%, 1 out of every $20 in the US is spent on primary care. Out of all that $3 trillion, only 1 in 5 goes to primary care. Probably not the model that you guys would want to develop if you were walking into a community abroad and saying, here's the best type of model we should support. In the US, it turns out we don't have that. Let me pause here for a second just to share this. The reason I'm passionate about sharing this with you guys. In 2002, I spent a year in Botswana working with the CDC, HIV, TB research. I was on a team with a whole bunch of incredibly expert folks. Got a fellowship to take a year off between my 3rd and 4th year. And in that year, I had more conversations with Botswana, local residents and the citizens of Botswana, who were challenging me on why why we wanted to use the American kind of model, right? And I didn't understand what their critique was about. They were giving critiques like, you guys spend so much money on this and spend so much money on that. It was wrapped up with a kind of a general geopolitical kind of critique. But I'm kind of starting to see now what they're talking about, right? Anybody work abroad and have those awkward conversations over a beer with a global partner where your partner is saying, what's going on with your country? What are you guys doing, right? I'm sure you guys have had that all the time, right? So part of it is driven by this. Let me skip ahead here. So the U.S. health disadvantage I talked about, let's really talk about why what really drives it. It can't be fully explained by the health disparities we have within the U.S. There's, to be sure, disparities and a disproportionate burden of pain and suffering and illness among the uninsured or the poor. And between racial and ethnic groups and socioeconomic groups, we have disparities as well. But again, as I said, even socially and economically advantaged Americans fare poorer in health compared to their peers. Why is that? So what's going on? What unites all Americans in faring poor? What unites all of us, rich and poor, in having poor health outcomes? It turns out it's social and environmental factors. The IOM underscored this point in their report about a year and a half ago. And it's one of the least told stories in the American healthcare education system, and it's important for us, I think, as we think about global health in the LA context and abroad, to make sure we understand what this means, social and environmental causes. We know, for instance, that social factors contribute about 60% to health outcomes, right? You guys have all seen the social determinants literature? Should I fast forward past this? No? All right, well, let me give you a quick example here. So social circumstances, environmental exposures, plus behavioral patterns account for about 60%. You might say, Rishi, why are you saying social circumstances and then behavior? Those are two different things. I disagree. Right? There are people who say how we live and how we work and how we eat are the main drivers of disease, and there are people who say, no, it's where we live and where we work and where we eat. Those are the main drivers. The reason it's a false debate is because, imagine the scenario here. If we took all the chairs out of this room, maybe left 10 back in the room and had you all come back inside to listen to this riveting speech, I guarantee you your behaviors would be different, right? If we changed the structure of this room, many of you would just leave. Some of you would stay, some of you would do that yoga. Some of you would, altruistically share a chair cheek to cheek with somebody else. Your behaviors would be different, though. You're making your own free will choices, but your behaviors, how you live, how you eat, how you behave, are determined by the places where we live and where we work. Right? This is the ways in which we can get past behavior versus social determinants in this way. And so if you see yourself in the global health context or domestically getting into a debate where it's like, tastes great, less filling, right? It's behavior versus social. Blow past that. It's a waste of time. They're interconnected, and social and environmental factors play a huge role. So in the US, food insecurity, for instance, is a major issue that we know about, and I'm just going to give this as a context of what this means. So when I say social factors, again, I remind you that I'm a practicing physician, right? And my eyes glaze over just like yours probably do when you say, okay, now we're talking about food insecurity or poverty. How do we take that on, right? I just want to go out and help that one individual and do that work. Well, it turns out we need to understand these factors because otherwise we're doing actually just mediocre work. So food insecurity, for instance, in California is linked to a 30% increased risk of just being hospitalized if you're a low-income diabetic. We know that social factors actually have a major influence. In the UK, a survey of over 40 million lives, a study that looked at 40 million lives, looked at an interesting analysis that looked at the risk of death from heart disease on the y-axis there to your exposure to green space, and found that, of course, the more exposure you had to green space after controlling for several variables, the more exposure you had to green space, the less likely you were to die from heart disease. Now, that association, not causation, but it's still a powerful correlation. And it raises a question for me as a practitioner. I know that to modulate a risk from heart disease, as a doctor, I know that there are certain cholesterol medications and blood pressure medications that I can use, but how do I prescribe a PARC, right? If this is actually something, if a patient of mine can benefit from being exposed to more green space and in that community context, why don't I, as a healthcare professional, someone who's dedicated my life to health, have the support and the systems to connect me to the public health resources to get somebody access to a tree, right? I'm being a little bit intentionally glib here, but it's important for you guys to see that this is part of what it's like when you enter into the healthcare workforce and you realize that your patients' lives come first. So one of the things that was so wonderful in 2008 when I was working in South LA, when this work was happening, the UN rapporteur came by, was that the WHO put this report together. Have you guys seen this report, the Closing the Gap in a Generation? It's the last kind of thing I'll recommend to you guys to read. Closing the Gap in a Generation was this wonderful report chaired by Michael Marmot, who talked really about social determinants of health and what we can do. Phenomenal report, a lot of great wisdom in this report, high-level kind of recommendations on how to advance equity, but through social determinants lenses. And I think I have a few minutes left, but as we think about this report, which laid out a lot of recommendations and actions like the ones you see here, talking not just about healthcare access, but talking about political empowerment, right? Talking about these other issues in one document. What it meant for me, again, as this clinician working in California, was what do we do, right? With all this in context, what do we do? And I realized working now 6 years ago in South LA that there was no home for folks like us, that what I was doing in South LA when we were building in programs on human rights, but we were also screening for hunger, we were screening for slum housing, and building those protocols in the clinic and having some modest success. When I realized that was out there, I realized I was still feeling frustrated because we had to learn these things on the fly. It was as if social determinants didn't matter. I felt like this pediatrician who emailed me a few months ago and said, help, right? I'm a primary care pediatrician, understand upstream approach for many years, no help, the city county is overwhelmed, I see over 30 patients a day, how to manage, would like to discuss. If you're somebody who's entering the healthcare workforce as a practitioner in terms of healthcare delivery or public health practitioner, this pain point is something that is currently in the space right now, and I ask you guys to challenge this. And the good news is there's a way. I'll just end by spending maybe 2 minutes talking about this. When I started thinking about this new way 6 years ago in South LA, I realized that there was no home for people like us, people in the clinics like myself who were spending our time living in the global health-informed human rights framework and then seeing patients and adjusting their diabetes medications. I realized there was actually other people that I started coming across who were like that, but there was still no home for us. So I thought a lot and interviewed a lot of people, friends, colleagues, mentors, and said, how do we form a home for ourselves? And one of the questions that came back to me was, well, how are you going to get to a new way while we're getting paid for the old way? Why that better bathroom kind of model is being implemented? What I landed on was a story that actually I'd heard from a public health giant named Adewale Troutman, and also was told to me by one of my patients who had shared this story because she heard it in church a couple of weeks earlier. The story was the Upstream parable. Have you guys heard the Upstream parable? You guys probably have heard this. You've had to have heard this. All right, here's my adaptation in a nutshell. You have 3 friends. Can I have somebody from this table just raise their hand? This table over here, yeah. What's your name? Asla. Somebody from the middle over here to help Asla out. You're not going to do any interpretive dance or anything like that, just something. What's your name, ma'am? Monica. Asla, Monica. And then what was your hand in the back? Karen? Asla, Monica, Karen. The 3 of you now have approached this beautiful scene. It's a beautiful scene. Congratulations. It's a great day. Unfortunately, it's pierced by the sounds of people now crying out for your help, right? Children, adults, the elderly. And so Asla, Monica, and Karen, what do you guys do? What should they do, guys? Help them out. Good. Good answer. Good. I know it's the end of the day, but it's good. That was good. So you jump right in and you help them out, and that's what all of us do, right? That's what you guys are aspiring to do right now with your careers going forward. You jump right in. Asla says, I'm a pretty strong swimmer. I'm going to help out those who are about to fall over the waterfall, those who are about to drown. I'm going to rescue those. We all celebrate those. The rest of us here in the room say, Asla, that's awesome. Let's give you all the resources you need. Of course we need more downstream rescue. Over time, Monica says, I have an idea. Let's build a raft. So a little bit further upstream so that fewer people are in need of Asla's rescue. And we say, wait a second, that's a great idea. You guys together, work that out. It's awesome. Success rate goes up a little bit. We're all celebrating it. And we think we're complete. Something happens though to Asla and Monica, or people like them. You guys are too noble and too committed, but other people feel jaded and cynical over time because they're like, wait a second, these people keep on coming. Come on, I'm getting tired. You start saying things to people, start saying this to people in the water, like, hey, didn't somebody teach you how to swim? Right? It's interesting because over time in the healthcare and public health space, we end up developing these weird kind of responses to the never-ending, ceaseless tide of people crying out for help. The good news is, over time, you guys look up and you're like, wait a second, Karen was with us, right? And Karen's way back over there. She's swimming. She's in the water. She's not pontificating from the side. She's not doing armchair warrior analysis. She's in the water. She's helping people. But she's swimming away from you. You're like, Karen, where are you going? There are people here to save. And Asla and Monica shout that out, right? And Karen shouts back, I'm going to find out who or what is throwing these people in the water, right? In the healthcare workforce, as it turns out, that parable hit home for me because we have Aslas, we have the partialists or the specialists, the ICU nurse, the trauma surgeon, the oncologist. We have people in the system whose help is vital and necessary. We're now in the U.S. in the era of the comprehensivist, right? Which is the raft builder, Monica's work. We're in the era of somebody who is now being that primary care clinician, part of a team of people who take care of you, keep you on track with your clinical preventative services, the mammograms, the pap smears, immunizations. But we know that there are people out there like myself and many other people, perhaps in this room also, who are a little bit off, doing some work in the system to optimize the way the partialists and the comprehensivists work. And those people who are thinking about ways to identify and address the social determinants are the upstreamists. As it turns out, there are a lot of people out there just like us, and when I started interviewing people, I ended up writing a book about it. And then I asked one of my upstreamist heroes, Paul Farmer, to write an afterword, and he said, sure. And then my day was done. I was going to drop the mic. That was it. So everything else is downhill from there. That was it. That was the pinnacle of my career. What ended up happening after interview with people who were legendary and people who were like residents and medical students and residents in different programs that I came across, people across the life cycle of residency and of medical education and of public health, what I realized was that there were people in the healthcare workforce who were doing something pretty similar. What they were developing was this idea of how to systemically address social determinants as part of healthcare. It's called social medicine, and it's been called this for a long time. But a lot of the upstreamists in the workforce today have actually figured out ways to do it. Fast forward a few years now, we have a network now, several thousand people and growing, of fellow upstreamists that are out there in the workforce, developing tools, helping them to identify ways they can take quality improvement, to think about how to move upstream, working with the Institute for Healthcare Improvement in Boston, thinking about how they can help support upstreamists to address social determinants. We found this idea that maybe at the intersection of population health and healthcare delivery, all these things, the quality improvement can help if we tweak it a little bit. These tools are starting to, we just had a talk to the IHI Open School, a platform for over like 260,000 members. So the word is starting to get out there, and we're only one among several people who are starting to push this idea forward and providing a home for folks like this. Providing tools to help people identify where they can move upstream. If you're somebody who's doing tertiary prevention in the emergency room, your upstream intervention can look one way, but if you're a primary preventionist and you're thinking about preventing diabetes, for instance, or preventing the ways food insecurity impacts diabetics, this is just an example of how to do that. There are these workshops that have been evolving, and it's incredible. What's been happening is that students, practitioners, and payers are starting to say, hey, how do we actually figure out how to address social determinants? And what's interesting about all this work is that there's been this change, and it's a change that I saw happen 6 years ago. When we started to do this work in South Central Los Angeles, not connected to any major institution, just using our sheer will and thinking about how we could take the passions that we had as global health informed local practitioners, we figured out that we could nearly triple our sense of confidence to address social determinants. That, I think, is the most important factor for your success. Because if you don't feel the sense of efficacy, the confidence to do something about the inequities that we talked about at the beginning, right? About all the different problems. If you don't feel like you have some efficacy in this, then that fuel that we need to drive Bernie, what does Bernie call it? The political revolution, right? To drive the change, it's quite simply that we want, right? That fuel is not there. My goal is to know that every one of you has a sense from the conversations today and from at least experiences like mine and others in this room, including Tom and Lee and Heather and Shirley. There are a lot of ways in which you guys can always stay plugged back into a network of mentors, of people who will always give you that sense of efficacy. Because when you're working in South Los Angeles or South Sudan, right? Or you're working in Central California, or you're working in CAR, right? Wherever you're at, the biggest driver of success for you is going to be your ability to go back home, connect to your mentors, and refuel and improve your sense of efficacy. When it comes to the US context, when it comes to what we're thinking about in communities both at home and abroad, I think a way to do that is to think about how to move upstream, to be conscious and get of the ways social determinants work, and to make sure you're challenging ways to become an upstreamist. And if you're not going to become an upstreamist, then be a damn good partialist or a comprehensivist. But always know that you need to support your upstreamists out there, right? If you have that third model, like Asla, Monica, and Karen, you guys can actually start working in a system that makes sense, that works, and most importantly, feels good to work in, right? That's all I have to say for you guys today, and thank you so much for the...